So this is our final case of the day, who is a 74-year-old gentleman who has background of hypertension, diabetes and hyperlipidemia. He presented with epigastric pain for 6 months, with OGD done in private, showing a 3 cm gastric SMT at fundus. Repeated EUS in November 2018 shows a 2 cm pedunculated cyst at fundus. Lesions was mainly intraluminal. CT confirmed a mild contrast-enhancing mass in the posterior aspect of the fundus, measuring 2.2 times 2.6 cm, and there's no obvious metastasis. And this is the CT image of the patient. And today we're going to do ESD for the fundal SMT.
So, carbon dioxide. Yes. So we use the Olympus 260G, the endoscope, to observe the lesion firstly, then decide which kind of method we want to use to just remove the lesion. This is the esophagus.
Posterior fundus.
So we could observe the lesion. So just near the fundus, the posterior wall of the fundus, this is submucosal lesion. So mucosa above the lesion is normal. Water inject, please. It doesn't take effect. So the mucosa is normal. So it is almost totally protruded into gastric lumen. I think lesion in this area is almost just gastrointestinal stromal tumor, and sometimes it is a leiomyoma. So water jet, please.
Is it a good position to do ESD?
So I think yes, it's maybe ESD or kind of the tumor evacuation technique to remove the lesion. Technique does something like ESD.
So I have one question for you.
Yes.
Dr. Peng.
Yes.
This area is very, very difficult to access. When there's a perforation,
Yes.
what is your strategy to ensure that you can close the perforation?
Yeah, and I think firstly, just avoid perforation if we could. Just resect, the superficial as a muscle layer and avoid perforation. If perforation happens, I think use two kinds of technique maybe. The first one is OTSC.
Okay.
Yeah, and second one is the loop technique with a loop as well as a metal clip, just to close the perforation. Maybe sometimes if the perforation is not very large, we only use the metal clip.
Oh, if it's not big enough.
Yeah, for the perforation.
Correct. Yeah.
So I want just to use the ESG technique to remove the lesion. What's your opinion?
Yeah, this is a little bit scary place. So I would be a little hesitant to do open the ESD technique.
Yes.
However, tunneling technique is almost impossible. Just going into the fundus.
Yes.
So probably that's the most feasible route to resect this lesion.
Yes.
The other possibility is to ask the surgeon to do
Surgeon. Yeah.
laparoscopic surgery.
So also, I think for surgeon, it's a very difficult place for surgeon because use laparotomy or maybe it's an open surgery, all very, very difficult to expose the lesion or resect the lesion.
Yep. If it's an anterior side, probably it's much easier for surgeons.
Yes, that's true. So I
Okay.
think, because the patients, only give general anesthesia, I want the patient to get intubated and remove the lesion.
Yep.
Yeah. So what's next? Intubation, please?
The intubation?
Yes?
Yeah.
Yeah.
I always ask the patient to be
Yeah,
intubated.
intubation, next step. Yeah.
Okay, so we're going to have a little moment to have the patient intubated first.
Do they have the full thickness resection device in Hong Kong? It's not approved in the U.S. for the upper GI tract, though, but I know Moen was talking about his experience using it for this.
So I contribute to the multi-center study as well. The full thickness device you can introduce to the stomach with the current format. The main issue is the size limitation. You have to get the tissue into the cap, and sometimes the lesion is too big to be coming into the cap.
Yeah.
So if the tumor is more than 2 centimeter, it gets a little bit iffy if you can really get the negative margin. So you have to just choose the battle. But that's one consideration. How big was this tumor?
And tumor, I think
Hold on, we have a question.
2.6 centimeter.
Yeah, that's
Hold
probably
on,
just
we have
too
one
big.
question.
Yeah. What's the question?
Yes, I'm Philip. So we don't have the full thickness device, and I think that lesion.
Sorry, it's the sound very.
Yeah, we cannot hear very well.
Sound?
Yeah, can you hear?
Yeah. Okay.
Yeah. I think we don't have the full thickness device at this moment, and I think this lesion is not feasible because the size is too big.
Yep.
But we may end up in a full thickness resection for that.
Yeah.
You know, from looking into the luminal appearance of that lesion.
Yes.
So we sometimes use Overstitch, but the position of that may also be challenging to use Overstitch.
Yeah, I was
Yeah,
going to
it
say
is.
to
Yeah.
suture in
So,
that retroflex position.
Yeah, maybe the nylon loop and the clip method, maybe the method of choice. Maybe.
Yeah.
Just for discussion.
Yeah. So I have no experiences of the Overstitch. How about you?
Yeah, I use the
lesion like this?
Overstitch.
Yeah.
The main issue is, as he described already, that the location in the fundus is very, very difficult to access. So my colleague friend Stavros in New York, he did Overstitch in the fundus, but he had to just make a loop going to the antrum and coming back all the way to the fundus
Yeah.
to reach there,
Yeah.
and which can be really challenging as
Yeah,
well.
I think so.
I think we should think that Overstitch wouldn't be really useful for fundus perforation.
Yes. So that's another question. I wonder for the lesion like this in Japan, is a kind of indication for endoscopic treatment, or the or laparoscopic or open surgery?
Is there any?
Any guideline or just meta-analysis and any data to show which kind of measures is suitable for these patients?
Well, there's no randomized study to compare endoscopic versus surgery.
Yes.
The main question is the access. So you have to individualize. You have to talk to the surgeon if how feasible it is. So the distance from the G junction is the key. If you're going to do wedge resection, you don't want to involve the G junction.
Yes.
That can compromise the G junction, resulting in stricture.
Yes, side
So-
effects. Yeah.
Yeah, if it's away probably 2-3 centimeter. Oh, sorry. Then probably surgeon would say, well, we can try. And this lesion may be possible to have the surgery done. But as you mentioned, the surgery on the posterior wall can be a little more challenging.
Yes.
So
Yeah.
if you can take it out, that's great for the patient.
Yeah. And before resect the lesion, do you think pathology is necessary? US FNA or some other kinds of methods to take biopsy?
It would be probably comforting for the patient that the patient is risking possible complications, or just accepting the risk. So in the stomach, we discussed yesterday, it's about 80% is a GIST, but 20% can be more benign stromal tumor. And the 2.6 centimeter doesn't mean that this is going to be a GIST for sure. So probably we tend to perform FNB for these type of lesion. Now, having said that, if you do FNB,
Yes.
if you try to do POET or stir, that can cause a fibrosis, and creating a pocket can be challenging.
Yes.
Have you had a problem before?
Yeah. That's true. And sometimes have the SMT, FNB, sometimes difficult, especially for small lesions.
Yep.
Yeah.
If
And
it's less than
also,
1 centimeter.
So as cytology is not enough for lesion like this. I think pathology is mandatory
Yep.
for this kind of lesion. But we can't have the 100% definite capture pathology for lesion like this.
Yep. And the European Society as well as Japanese Society, this interest group recommendation for just less than 2 centimeter, if it can be removed safely, they are not recommending to have pathological diagnosis first. So if this is a case that you can remove easily, if it's less than 2 centimeter,
Yeah.
probably it's okay not to have a pathological diagnosis.
Yeah.
If
Dr.
it's just
Lee, Dr.
intermediate
Fukami?
size,
Sorry,
if
we have
you
to
want
cut- we're going to have to cut our discussion short.
Yes,
Okay.
Norio,
so,
you're
sorry, that was a
closing
great
it down
discussion.
again.
Yes, because of time, I guess we have to close the section. But we will record the show and we
Yeah,
will
and then we can
will play
update
it
everyone tomorrow with your decision.
Yes,
Yeah.
thank you
It's
so
a-
much.
It's a
Thank
time.
you.
Yes, thank you.
Thank you.
Yeah.